David Golombos. I am a urologic oncologist here at Rutgers Cancer Institute of New Jersey and an associate professor of surgery at the Robert Wood Johnson Medical School. First of all, I would say strength in numbers. Prostate cancer is extremely common, and there's an estimated to be over 3 million men living with prostate cancer in the United States alone. Second, prostate cancer screening traditionally consists of both a PSA blood test and a digital rectal exam. I've had numerous conversations with men who've relayed to me that they've been hesitant to undergo prostate cancer screening because of the rectal exam component and their comfort level with it. So I would say to them that by far and away the more important of the two screening components is the PSA blood test. And there's a lot of information that can be gleaned about a man's risk of harboring undetected prostate cancer from that test alone. Finally, I think it's important to understand that modern day management of prostate cancer is a lot different than we used to treat the disease in the past. We have numerous different treatment options, many of which can minimize quality of life side effects and preserve things that are very important to men, such as potency and continence. And I would say for those diagnosed with prostate cancer, it's extremely important to voice your concerns and your values so we can make sure that the right treatment is being applied to the right patient. One of the largest United States healthcare disparities exists in prostate cancer. African American men are about 1.7 times more likely to be diagnosed and more than 2 times more likely to die from prostate cancer than other races. And this disparity is the result of a complex network of factors, including socioeconomic status, access to care, environmental exposures, and disease biology. So current research suggests that if we were able to kind of minimize access to healthcare, then we would be able to significantly reduce the gap in this disparity, but it would not completely eliminate it. So this highlights the important role of understanding how the disease biology differences between different races who are affected with prostate cancer. It's extremely important that, as a medical and a research community, that we continue to look into and try to understand this complex relationship. So here at the Rutgers Cancer Institute of New Jersey, we have a working group that consists of epidemiologists, scientists, and clinicians that meets every month, where one of our main focuses is trying to further understand this complex relationship, and both within our New Jersey communities and across the United States. So the proportion of prostate cancer that is thought to be directly attributable to hereditary conditions is somewhere between 5 and 15%. So germline or genetic testing is really indicated for those men who have a family history suggestive of a hereditary component. So that's really men with a family history of very early diagnosis of prostate cancer, metastatic prostate cancer, or lethal disease, or men with a family history suggestive of breast, ovarian, or colon cancer syndromes. So right now, I would say the most important racial or ethnic consideration revolving around prostate cancer is screening. Your average risk man, most guidelines suggest should begin screening around the ages of 45 to 50. However, for men who are at higher risk, specifically African American men or men with a strong family history of prostate cancer, should really begin screening for prostate cancer earlier at around the age of 40. And I think the other component of kind of prostate cancer where we're seeing an increased role of understanding the importance of race is with active surveillance. So active surveillance is a treatment strategy for men who are diagnosed with what's thought to be low risk or indolent disease. And that's where we watch the cancer with close surveillance, with the understanding that if we see a transition or progression to higher risk disease, that we would step in with curative treatment. Studies have shown that African American men who opt for active surveillance are at a higher risk of progressing to more significant disease than their Caucasian counterparts. So one thing that we look at when trying to select appropriate candidates for active surveillance is what's called genomic testing, where we send the cancer for molecular analysis to kind of further understand the risks of being on active surveillance. And I think this is especially important to do when appropriately selecting African American men who might be candidates for active surveillance, to make sure that we're pairing them with the appropriate treatment strategy. Some risk factors such as age, race, and genetics are unavoidable. Well, thankfully, there are some risk factors that men can control. Try to reach and maintain a healthy weight. Exercise regularly. Limit red meat and saturated fats. Steer clear of highly processed foods. Try to incorporate cooked tomatoes and cruciferous vegetables such as broccoli and cauliflower into your diet. Drink alcohol only in moderation. If you smoke, try to quit and get screened.